Welcome, everybody. So we're going to go ahead and get started. I'm Susan Hedstrom, the Executive Director for FPWR. I'm also the mom of a young boy, Jaden, who's 11 years old and has Prader-Willi syndrome. I will be acting as your moderator today for our 2020 Virtual Schaaf-Yang Syndrome Conference. It's not every day that we get to bring together three of the world's greatest experts in Schaaf-Yang syndrome, but today that is exactly what we're doing. Joining us today, we have Dr. Christian Schaaf joining us from Germany, Dr. Rachel Reverick from Alberta, Canada, and Dr. Ryan Potts. Dr. Schaaf will be presenting with us today first, and then later on today we'll have Dr. Reverick and Dr. Potts.
Okay, perfect. Well, I'm so glad that we can get together, at least virtually, and I miss you all. And would have loved to meet you in person in Chicago. But I'm glad that we have the opportunity to exchange some ideas about what we've learned about Schaaf-Yang syndrome over the past 7 years. And I greatly look forward to your questions and can't really wait to meet you all in person again at the next in-person family conference, wherever and whenever that may be. It's around 6 p.m. In Germany, and as you can see, the sun is setting behind Heidelberg. You see the old city here with the castle and the university where I have my offices and research labs, and the clinic is just behind that green hill on the right side of the river. I have very fond memories of our past family conferences. The first one in Indianapolis 3 years ago, and then also the one in Las Vegas, where I got to meet not only many of you, but also your wonderful children, from whom I have learned so much and continue to learn so much over the years. I have prepared a presentation for you today that focuses really on the clinical aspects of Schaaf-Yang syndrome. And it's a hybrid presentation. Some of the slides that I included are slides that I've shown in the past, because I realize that there are families on the call today who have not been able to be present at the past family conferences, and also families whose little ones have only been diagnosed within the past months or years. So I've included some Schaaf-Yang syndrome 101, just to give you the basics of what you need to know. But then also I have some new data that I wanted to share with you, highlighting some new publications and manuscripts of our research studies that have just come out. We have a research study on sleep in Schaaf-Yang syndrome that was published just a few weeks ago. And then just last week, we had a manuscript accepted for publication that highlights the adult phenotype of Schaaf-Yang syndrome, which is a question that I realize is very important for you all as you wonder what the future will bring and what adult individuals with Schaaf-Yang syndrome are challenged with. Finally and lastly, I also want to highlight some ongoing work. I'll be very brief on that, but that's more the basic science research that's happening in the lab as part of a study that is ongoing and that's actually funded by FPWR. So let's get right in. Schaaf-Yang syndrome kind of traces back to 2012. I used to work in Houston, Texas for approximately 12.5 years at Texas Children's Hospital, where I did my training in medical genetics. And I became an expert in the genetics of autism spectrum disorder. And in 2012, in my clinic, I had a young man come to me for a clinic appointment from Arizona. His name was Donnie, and he was a rather curious case, unusual case with autism spectrum disorder. As one of the first questions his mom asked me was whether Donnie had Prader-Willi syndrome or not. And Donnie then became the first individual with a MAGEL2 mutation and the condition that was later named Schaaf-Yang syndrome. Once we had identified Donnie, we quickly identified an additional 3 individuals with mutations in MAGEL2 and reported those 4 individuals and their clinical features in a manuscript in Nature Genetics in 2013. 2 years later, OMIM, which is a group of people at Johns Hopkins University in Baltimore, who take care of the cataloging and naming of genetic conditions, decided to name this new disorder, which we used to call MAGEL2 associated disorder. They decided to name it Schaaf-Yang syndrome based on our initial publication, with me being the first author of that manuscript, and Yaping Yang, who used to be the director of the exome sequencing lab at Baylor College of Medicine in Houston, who was the last author on that manuscript. And then only 2 years later, we had the first family meeting in Indianapolis. And looking back and considering that it's only been 8 years, I feel that we have really come a long way, and we have learned a great deal about this new disorder, the clinical manifestations, the specific strengths and challenges of the individuals affected. But also we're beginning to learn a big deal about the molecular mechanisms underlying Schaaf-Yang syndrome, its relationship to Prader-Willi syndrome, and potentially we are also making some headway in regards of getting some ideas of potential therapeutic avenues for the disease. So while for many of you this may seem very slow, as you are certainly hoping to get therapies and medications treating your children yesterday rather than tomorrow, I feel that we as a community, medical and scientific community, in very close interaction and collaboration with you all, the families, have really made tremendous progress over the past 8 years. And I certainly hope that we can keep that momentum going, and with the support of the foundation and other funding sources, will continue to make tremendous progress over the next decade. Let me see. Oh, this is a picture of Donnie at the time that I saw him in clinic. So I want to start with some Genetics 101, just so that everybody is on the same page and that you all feel that you actually understand what the genetic changes that relate to Schaaf-Yang syndrome imply. These graphics were actually made by Sean McDade, who is the father of a little girl with Schaaf-Yang syndrome. And I used those with his permission. So our body is made up of trillions of cells, and within most of those cells, there is a nucleus. And within the nucleus, we have the genetic material that is located and stored on structures that are called the chromosomes. We have 23 pairs of chromosomes typically within each nucleus, of which half comes from dad and the other half comes from mom. So when the egg, when the egg is first fertilized by the sperm cell, 23 chromosomes from the mom come together with 23 chromosomes from the dad, making up 23 pairs for a total of 46 chromosomes. The chromosome that's most important to us right now, as this is where everything that relates to Prader-Willi syndrome and Schaaf-Yang syndrome happens, is chromosome 15. We have 2 copies of chromosome 15, and on the long arm of the chromosome 15, there is a region that is called the Prader-Willi syndrome region, or the Prader-Willi syndrome critical region. The exact coordinates are between 15q11 and 15q13. Now, there's something very unusual about this region, as for most of the human genome, both copies are equally used, the mom's copy and the dad's copy. But for this region on chromosome 15, only the paternal genetic sequence is actually active and used within the cells. The copy that comes from mom is silenced, or we call it imprinted, meaning that all the instruction manuals that are there are locked away and the body cannot really access them. Now, Prader-Willi syndrome can have several causes, one being a deletion, meaning a piece of chromosome 15q11 to q13 missing. But another cause of Prader-Willi syndrome is if the entire chromosome 15 from dad is lacking, and instead the affected individual has 2 copies of chromosome 15 that come from mom. So the overall material is the same, but instead of having 1 from mom and 1 from dad, those individuals have 2 copies that both come from mom. Within the Prader-Willi syndrome region, there are several genes, and the genes encode for proteins that then fulfill certain functions within the body. One of those genes within the Prader-Willi syndrome region is MAGEL2. And mutations within this gene can cause Schaaf-Yang syndrome. But because I told you that for this particular region on chromosome 15, only the paternal information is active, only the copy that comes from dad is active. That also means that only mutations in the paternal copy of MAGEL2 will cause Schaaf-Yang syndrome. Because the instruction manual that comes from mom that has the title MAGEL2 is locked away and is not used. So for Schaaf-Yang syndrome, it doesn't matter if there are mutations on the maternal copy because they're not used anyways. But as soon as you have a mutation in the paternal copy that is of the type that we'll be talking about, then that individual will manifest Schaaf-Yang syndrome because it's the only copy of that instruction manual that's used, as the body does not have access to the leftover instruction manual that comes from mom. So why is the Prader-Willi syndrome test negative in kids with Schaaf-Yang syndrome? I realize, and you may realize, that many of your children had like a suspicion for Prader-Willi syndrome was raised at some point in their diagnostic workup. And I believe that for more than 80 or 90% of your children, a Prader-Willi syndrome test was ordered. But that comes back normal. And why is that? That is because your children do not have that piece of chromosome missing. They do not have a whole chromosome 15 missing. They only have a tiny itty-bitty point mutation within the MAGEL2 gene, and that mutation cannot be detected with the standard Prader-Willi test. So I'm showing that here. The type of mutation is very different. It's on a whole different level. If you think of the chromosomes as, let's say, big maps of a country, like a map of the United States, you will see if Texas is missing on that map. And that's kind of the, the size of chromosome material that's missing there. But you will not be able to zoom in and find out if Main Street is present in Houston or not. So for that, you need a much, much higher order of magnification because you really, for Schaaf-Yang syndrome, need to get to the single letter level within the gene. And for that, you need a whole different test. So how is Schaaf-Yang syndrome diagnosed then? In order to identify those single base substitutions, you need to do gene sequencing. And there are generally 2 different types of tests that will detect those mutations in MAGEL2. For most of your children, it was detected by whole exome sequencing, which is a very extensive sequencing test of all the protein coding genes in the human genome that is ordered mostly for children with multiple malformations or congenital disorders that come along with developmental delay, intellectual disability, autism spectrum disorder, or generally very complex medical situations that the physicians cannot figure out what that disease is. That test has been clinically available in the United States since 2011. And at this point, I believe that more than 90% of your children have been diagnosed with whole exome sequencing. But we also have some kids who were diagnosed with single gene sequencing. And that is because, I believe, we have done a fairly good job in educating the medical community about Schaaf-Yang syndrome over the past 8 years. Now, certainly, Schaaf-Yang syndrome is a very rare disorder, and there are many, many physicians out there who have never heard of Schaaf-Yang syndrome before. But we have tried our best to publish information about the condition. We have tried our best to go to various international conferences and present about the condition. Actually, most recently, a colleague and I have written an article for a website that's called Gene Reviews, which is used by geneticists and other physicians around the world whenever they want to learn about genetically caused disorders, which summarizes all the current information about Schaaf-Yang syndrome. And so we continue to educate the medical community. And by doing so, there have been physicians out there who have seen some of your kids who looked at your children and read the medical history and felt that the combination of features that they saw was reminiscent of a disorder that they had learned about, being Schaaf-Yang syndrome. And so they felt confident enough to order not the sequencing of the entire genome, but to order sequencing of only one out of those 23,000 genes in the human genome, namely MAGEL2, because they had a strong suspicion that this may be Schaaf-Yang syndrome. And so about 10% of the kids have now been diagnosed by sequencing of only that one gene. Many of your kids are the only cases, the only affected individuals within the family, but there are also familial cases of Schaaf-Yang syndrome. We have some families on the call here where more than one child is affected with Schaaf-Yang syndrome. And we've also been in touch with families like the one on the bottom here, where all the affected individuals will be labeled as black squares or black circles, and where more than 10 individuals within the extended family have been affected with Schaaf-Yang syndrome. Why is that? Why can Schaaf-Yang syndrome run in the family? Well, it can run in a family, and the gene and the mutation can be passed on from one generation to the next as long as it goes through the maternal line. So whoever inherits the mutation on chromosome 15, which comes from mom, will carry the mutation, but will not be affected with the disease because he or she will carry the mutation on the maternal copy that's locked away. But as soon as a man passes on mutation to his children, then those children who inherit the mutation from him will be clinically affected. So we see that here. These are the different scenarios that we see amongst all of you. We have, I would say, about in half of all cases, de novo mutations. Maybe it's a little more than half. De novo cases means that the mutation, your child is not only the only one affected in the family, but when you and your spouse were tested for the presence of the mutation in your blood, the mutation could not be found. So it's presumably a very new event that happened at the formation of either the sperm or the egg cell. Then we have the inherited cases that I just alluded to, where the mutation runs in the family through the maternal line, but as soon as it's passed on from a dad to his children, the children will be affected. And then we have a third scenario. And there are, I think, 2 families who we are in touch with right now, where both parents were tested and none of them was found to carry the mutation. But still, they had more than one affected child with Schaaf-Yang syndrome. And that situation is not entirely unfamiliar within the world of human genetics. We would call that a presumed germline mosaicism. So you know what a mosaic is. Basically, this refers to the germ cells of one of the parents, where they are a patchwork where most cells will not carry the mutation, but there are some cells in between, some little stones in between, some sperm or some egg cells that carry the mutation. And why is that? That is, or we think it is, because the mutation did not happen at the very last stage when the sperm was formed that made it to the fertilization of the egg, or the egg that was fertilized by the sperm. But it happened at one of the earlier cell cycles, and then that sperm, that early sperm, carries the mutation. But when it keeps dividing, all the other sperm that arise from that one where the first mutation happened will also carry the mutation. This is something that we see in genetics every once in a while. It's not very common, but we have to inform you all because it has implications regarding the chance of recurrence and the chances of having another child with Schaaf-Yang syndrome. So what are those chances? We say whenever a child was found to have the MAGEL2 mutation and both parents were tested, and we only test the DNA that comes from blood or another tissue like a buccal swab or a spit sample. Either way, if both parents are found to be negative for the mutation, we will tell them that the chance for each additional pregnancy of having another child with Schaaf-Yang syndrome will be less than 2%. It's never zero, nothing is zero in medicine, but in this particular case, it's not only not zero, but it's also slightly elevated compared to the general population because of the remote possibility that one of the 2 parents could have a germ cell mosaicism, meaning that we don't see the mutation in blood, but there could be some cells in the germline where the mutation is still present that could lead to another child with Schaaf-Yang syndrome. And then the other situation is very different. If dad is found to carry the mutation and is clinically unaffected, we assume that the mutation is on the maternal copy in him. And in that kind of scenario, the chances for each additional child will be 50% of inheriting the MAGEL2 mutation. And when that MAGEL2 mutation that caused Schaaf-Yang syndrome in one child is inherited from dad in the next child, that child will also develop the clinical features. Okay, so here come my first 2 polling questions. Susan is pulling those up. So my first question for you all, when was your child diagnosed with Schaaf-Yang syndrome? Were you all diagnosed prenatally? Was your child diagnosed between birth and the 1st birthday, between the 1st and the 10th birthday, or after the 10th birthday? So Susan is showing us the results. None of your children were diagnosed prenatally. You know, we do have some families where kids were diagnosed prenatally. Those could either be the siblings of children who already have Schaaf-Yang syndrome, or could also be a situation where, for example, fairly severe contractures were present prenatally and genetic testing was initiated. But none of those seem to be on the call today. We do see that most of your children were diagnosed between birth and the 10th birthday, and it's about half-half between those 2 groups. That is typically what we see in clinical practice as well. So there's a good amount of kids, especially within the last 2 or 3 years, that the condition has been more well established, where that genetic testing was initiated early because your children manifested hypotonia, feeding difficulties, maybe hypogonadism, underdeveloped testicles or undescended testicles, and typically contractures. But then we also have an equally large fraction of children that were diagnosed between the 1st and the 10th birthday, because then other features become obvious and maybe even more prominent. Those typically relate to cognition, developmental delay, certain behaviors, autism spectrum disorder, and others. And then we have 15% on the call today whose children were diagnosed after the 10th birthday. And that could be because some of those kids were diagnostic mysteries for many years, maybe even before the condition was known and first reported, or because the appropriate testing was not available at that time, such as exome sequencing, which has only become available over the past years. So thank you, Susan, and we can move on to the second question, the second polling question. Okay, so do you know your child's specific mutation and what it means? First, I don't know the mutation. Second, I know the mutation, but I have no idea what it means. And then third, I know the mutation and I do have some understanding of what that means. Okay, we can look at the answers. So 13% of you do not know the mutation. I do encourage you, if you don't know the mutation, to ask for a copy of the genetic testing report so that you have that on record, which is really important when someone asks. Also, I do like to encourage you, if there are some people on the call who haven't been in touch with me or my group, that you reach out to us. I will give you my email address at the very end of the presentation, because we do like to keep track of the entire group of individuals diagnosed with Schaaf-Yang worldwide and keep somewhat of a registry where we tabulate the information so that we can better understand the whole range of mutations and also the whole range of clinical symptoms that we see. And then we have about a third of people who know the mutation but don't really know what it means. And about half of you know the mutation and have somewhat of an understanding of what that means. And I think that is quite surprising for a rare genetic disorder, because what I typically see in clinic for all comers is that people do have a copy of the testing report, but they really have no understanding of what that means. So that makes me a little proud of you all and also of us physicians and geneticists, that it seems that we have done a good job of trying to educate you and explain to you what that really enigmatic kind of coding of genetic information means and how it relates to clinical features. So we can close the poll. Let me see, I can close that. Okay, and we can move on with the presentation.
Could I interject for just a moment? We do have a relevant question, which is—
Okay, absolutely.
If you have children and your first children are typical, so you wouldn't believe that they're carrying a mutation, and then you find that your subsequent child does have this mutation, should your family be tested? Should your typical child be tested for being a carrier?
Yeah, that's a very good question. I do not believe, based on what we know today, I do not believe that those typical children need to be tested. At this point, I personally do not have any evidence that when you inherit a mutation from your dad that can cause Schaaf-Yang syndrome in one child, that other children of yours could carry that mutation and be clinically unaffected. That is a phenomenon that is, present for many genetic disorders. It's called incomplete penetrance. But that phenomenon of incomplete penetrance to this date has not been described or reported for Schaaf-Yang syndrome. So in my clinical practice, when families come who have 3 or 4 children and the newest child to the family is found to have Schaaf-Yang syndrome, I do not see a need to test the other children. Okay, so that being said, we'll move on with the presentation, and I'll show you some slides that dig deeper into the nomenclature of the genetic mutations and also give us some understanding of the landscape of mutations that we see. So at this point, my group is in touch with more than 250 definitive cases of Schaaf-Yang syndrome. And in a publication that came out about 2 years ago, we plotted the mutations that had been known at that point, and kind of the general gist of this is still the case today. So we see a cluster of mutations in the middle of the gene. This gene is comprised of genetic letters that go from letter number 1 to letter number 3750. And those letters are later translated in the cells into an amino acid code, which will make a protein. And the protein building blocks also have numbers from number 1 to number 1249. The majority of mutations is right in the middle of the gene, and there's one particular site that is letter number 1996, where about half of all mutations happen. So we certainly know more about that particular mutation than any other mutation to date. So let's look at the coding and also try to understand what a mutation really means. So when you look at your genetic testing report, it will say something about the MAGEL2 gene. And then typically you see these combinations of letters and numbers. I just took out one example to illustrate what those mean. So first, there's a nucleotide code, which is the C and then a number and then a letter changed to another letter. And then you also get some information about the protein code, and that one starts with a little p and then a letter and a number and a letter. So in the nucleotide code, C stands for coding sequence, and that combination of numbers and letters illustrates the change on the DNA level. So in the DNA, in the nucleotide number 2909 on the DNA level, there's supposed to be a G, but in that particular child, instead of a G, we find an A. So G was changed to an A. And then the second one is the protein code, and here the little p stands for protein sequence, and that illustrates the change on the protein level. So in this particular case, the amino acid that's abbreviated with the letter W, which is in position 970, is changed to something. And in this particular case, it's an X, and the X means that it's not changed to an amino acid, but it actually causes a stop. So the X is like a stop sign, and it means there's an immediate stop within the protein sequence. We call that a nonsense mutation, which causes a truncation in the protein. So for most of your children, I assume that in the protein code, you will see an X or an asterisk, which basically means the same, or there will be something written with an FS, which means frame shift, which means there's a change. So the change on the nucleotide level, on the DNA level, will cause a frame shift in the coding, and thereby will also lead to many errors on the protein base and will ultimately cause a premature stop. So all the cases that I've mentioned so far, those 250 individuals, they all have these stop mutations or truncating mutations. Are certain mutations more severe than others? So we've come to realize a few things over the past year. There's one mutation, which is the C1996 del C mutation, which to date is by far the most severe mutation. It's often lethal. In many cases, it's lethal even before birth. In some cases, those children have been born alive, but with very severe malformations, and then passed away within the first days or weeks of life. This mutation has been reported in, I believe, less than 10 individuals to date. Then we have the most common mutation, which is the C1996 dupe C. So you can see it's in the same position, but instead of a deletion of a cytosine, we have a duplication of a cytosine. So instead of having the lack of a letter on the DNA basis, we have one additional letter. So it's a very subtle difference, but it makes a big difference on the clinical level, because for the C1996 dupe C mutation, in the vast majority of cases that we're in touch with, that is very well compatible with life, and it causes classical Schaaf-Yang syndrome with many of the features that I will go on to describe. However, we have compared that entire group of people with the C1996 dupe C mutation to all the other individuals who have other MAGEL2 mutations, and we've come to realize that those with the C1996 dupe C mutation are slightly more severe than the rest of the group. And then there's a fourth group, and those are the ones who do not have any of the nonsense or frame shifting or truncating mutations. Those are individuals who were found to have a misspelling in MAGEL2, but it's only a missense change. Missense change means that on the amino acid level, one amino acid in that particular position of the protein was exchanged and replaced by another amino acid. There's a growing number of individuals that are reported to us with missense changes in MAGEL2, and we continue to study those and investigate those. In fact, I just met with one of my newest physicians on the team a couple of weeks ago, and we are beginning a new project where we'll look more deeply into the implications of those missense changes. And I do know that Rachel Veverick, who is on the call today and who will be presenting later, also has a research project that is looking into the implications, possible implications of missense changes in MAGEL2. Okay, so in the next part of the presentation, I will summarize the clinical features of Schaaf-Yang syndrome. And as I mentioned before, those can also, they can already be present during pregnancy. I believe that most of you had what would be reported as a generally uncomplicated pregnancy. And for most of you on prenatal ultrasounds, nothing major was found. But there are some things that have been reported in a subset of cases and that may have been present. Some of them may also have been present in retrospect, such that you and your physician didn't realize at the time that it was meaningful, but looking back, you may realize, yes, that was there, especially compared to some of my other children. So we do see somewhat decreased fetal movements in children with Schaaf-Yang syndrome, and that in part can lead to polyhydramnios, which means an increase in amniotic fluid that surrounds the baby in the uterus. Also, in some cases, we have already seen contractures of the finger joints, or sometimes also of the larger joints on the prenatal ultrasound. But especially to recognize the contractures of the finger joints, you need a very good ultrasound machine and a very experienced ultrasonographer. So I'm not surprised that in many cases, children have been born with contractures, but it was not really recognized on the prenatal ultrasounds. Then infancy and childhood. This is the time when the majority of your children have been diagnosed. And that's not surprising because that's really when the symptoms become very evident. In many of your children, the symptoms were immediately evident when the child was born. And why is that? Because the APGAR scores were low. The baby had very low muscle tone, wasn't vigorously moving and crying right away. Within the first few days of life, did not latch very well and did not breastfeed very well, and may have needed support with feeding. And many of your children have been tube fed, at least for a couple of days or weeks, in some cases months and even years. Many of the boys have somewhat underdeveloped genitalia, especially undescended testicles. And then as the kids get older, we realize other things that come on, such as developmental delay, that then leads to intellectual disability, and also unusual behavioral patterns, oftentimes diagnosed as autism spectrum disorder. A subset of kids, I want to say about 25% of kids, have further complications. And those often involve apneic episode, breath holding spells very early on that can be severe. We have a good number of children who have generally respiratory problems that require them to be intubated and on mechanical ventilation. Some of them don't really come off the ventilator very well and need a tracheostomy and then go home on tracheostomy. It seems that about 25% of children with Schaaf-Yang syndrome have those more severe respiratory complications. And here I want to give you an impression of what some of your kids look like. There are certainly some shared physical features and facial features. And I think some of you will attest to that, as you have come to realize when we meet at the family conferences and you get to see each other's children, that some of them look like siblings, even though obviously they have completely different parents. And the kids amongst themselves with Schaaf-Yang syndrome may look more similar to one another than each child with Schaaf-Yang syndrome looks similar or dissimilar to his or her biological siblings. I think some of the features that we do see, especially in early infancy, include the relative midface hypoplasia, so the relatively small midface, but a large forehead, sometimes very prominent, sometimes even bulging forehead, with a slight depression on the sides. Oftentimes we have fairly chubby cheeks that can be present. And then kids kind of grow to become older, and I actually feel that they grow out some of those specific facial features. And especially for the older children, there are many who don't really look any different from comparing them just based on seeing them to other children their age. The hands of Schaaf-Yang syndrome are somewhat unique, and they are also quite a distinguishing feature from Prader-Willi syndrome. Because the vast majority of your children have contractures, especially of the small finger joints, so that many of your children were not able to fully extend their hands at the time that they were born. They require physical therapy and occupational therapy, and oftentimes that gets better over time, but only with intensive therapy. Some of them have also, in the more severe cases, have even required surgery to release some of the tendons and allow them to fully open their hands. In addition, that's not really physically relevant or functionally relevant, but when you look at the fingers, many of your kids have tapering fingers such that the finger becomes more narrow towards the tip of the fingers. And then we want to look and talk about some of the other body systems that play a role in Schaaf-Yang syndrome. And one of those body systems is the endocrine system. The MAGEL2 gene is especially expressed in the brain, and within the brain, especially in the hypothalamus, which is somewhat of a master regulator of the endocrine system in the body. And as a consequence of the MAGEL2 mutation there and the dysregulation that's caused by that in the endocrine system, many different alterations can happen and many different hormones can be changed into various directions. So we realize that many of your children have growth hormone deficiency. We do see in some of your kids altered glucose tolerance, and we see abnormal hormones related to food intake and satiety. And then in addition, we also see alterations on the sex hormone level that will cause the hypogonadism that I just described in some of your kids. Now, growth hormone deficiency is an area of great interest to many of you because growth hormone is an FDA-approved therapy for Prader-Willi syndrome. And a lot of experience has been gathered for growth hormone treatment among children with Prader-Willi syndrome. So with that, I want to get to the next polling question because I really want to understand and see from you all how many of your children have received growth hormone treatment in the past. So our question, has your child ever received growth hormone treatment? No. Yes, but we didn't see any changes. Yes, but there were negative changes and we had to stop. Or the fourth answer option, yes, and there were positive changes. Okay, so we can look at the answers. So, wow, this is also surprising to me because we haven't really systematically asked all of you. So about a third of your children have not received growth hormone treatment. And there are multiple reasons for that. The first and foremost reason, growth hormone, recombinant growth hormone, is not an approved therapy for Schaaf-Yang syndrome. That does not mean that it cannot be given to children with Schaaf-Yang syndrome, but it would be considered an off-label use. So the physician, typically a pediatric endocrinologist, would have to sign off on that. And some physicians are just very careful and they feel quite uncomfortable signing off on this treatment without any substantial evidence in the medical literature. So I've been in touch with many of you, and some of you have asked me to issue a letter where I explain the relationship between Schaaf-Yang syndrome and growth hormone. Some of you have then been able to get growth hormone therapy approved as a consequence of that. And then it seems that many of your children have actually been on growth hormone. It's quite exciting to see that none of you have had to stop the treatment because of negative consequences. Some, as expected, I would see, but a small number have not seen any major changes. But a very large number of you have seen positive changes coming with growth hormone treatment. So we will be building on this experience, and I also have a new member on the team who is a medical student interested in Schaaf-Yang syndrome research. And we just put together a questionnaire all around growth hormone. Has your child been tested for growth hormone deficiency? How was your child tested? What were the results? What were the physical findings prior to the initiation of growth hormone treatment? Was your child put on growth hormone treatment? How long did your child receive or has your child received growth hormone treatment? And what are the consequences? Can you submit your growth charts? Can you tell us about the changes that you have seen as a consequence of growth hormone treatment? So we will be sending out that questionnaire to the families who are in our database for whom we have the contact information. And I will also post something in the closed Facebook group. I would be most grateful if many of you were willing to fill out that questionnaire and send it back to us. So that being said, do we have one more polling question? Yes. Sleep study. This actually relates to growth hormone treatment. I'll get to that in a minute, but we certainly do recommend prior to the initiation of growth hormone treatment for your child to have a sleep study first. So I want to know from you, has your child had a sleep study at any point, and what were the results? First, never had a sleep study. Second, had a sleep study and it was all within normal limits. Third, had a sleep study and was found to have sleep apnea. Okay, let's look at the results. So this is on one hand good information because it shows that the vast majority of your children, 90%, have had a sleep study. That's really important, and that also shows that we have been doing a fairly good job educating you and your physicians because I strongly believe that every child diagnosed with Schaaf-Yang syndrome should have a sleep study within a few months after diagnosis. And then the sleep specialist, in conjunction with us, should decide how often that should be repeated. Now, the negative information that we are sharing here is that unfortunately, in many cases, the sleep study is abnormal. And this goes hand in hand with the information that we have gathered and the publication that I'll go on to present in a few minutes, that many of your children do have sleep apnea. So we can close the poll and we can move on with the presentation. So additional common features of Schaaf-Yang syndrome, sleep apnea. So based on the information that we gathered by questionnaires in the past is that approximately 3/4 of all children have sleep apnea. It could be obstructive, it could be central, or it could be combined sleep apnea. Most commonly obstructive sleep apnea. And then respiratory problems are common in some cases, like I mentioned before, about 1/4 of cases, they are so severe that your children require intubation, and some of them even go on to have a tracheostomy. We see that here. A history of intubation, actually, at any point, more than 50% of all the families report a history of intubation at some point in their children when we gathered that information 2 years ago. And about 18% of all children have a history of tracheostomy. And then third, feeding problems are very commonly seen. Dysphagia in 97% of all children, which means a difficulty swallowing and altered mechanisms, altered function of the swallowing process. And a history of tube feeding is reported in 3/4 of all of your children. Now, let's get back to sleep. And this is the publication that I mentioned a few times already that just was published maybe 2 weeks ago. It is mostly a study that was conducted by Weston Powell and Joanna Reed. Joanna Reed, who's a sleep specialist at Seattle Children's Hospital in Washington State. Joanna also attended the Schaaf-Yang Family Conference in Las Vegas 2 years ago. And together with Weston and Joanna, we reached out to many of you and asked you whether you would be willing to submit the sleep studies that were done on your children. And those were submitted to Weston and Joanna, who then carefully reviewed those sleep studies and looked for commonalities and differences between those children. So the results of that study, summarized on one slide in just 5 bullet points, are the following. All of you who are interested in reading more about it, I'm happy to send the manuscript out to you. I also posted the PDF of that publication in the closed Facebook group. But I realize it's very technically written, really for sleep specialists. So some of that nomenclature is even very difficult to understand for me, who obviously studied medicine, but is not a sleep specialist myself. But the main information of that paper, they analyzed the sleep studies of 22 children with Schaaf-Yang syndrome. And they found that sleep disordered breathing is very common within the cohort and most commonly due to obstructive sleep apnea. So what does sleep disordered breathing mean? It means that the breathing is abnormal during sleep. And there are also multiple kind of anomalies about sleep in general, some of which they report in greater detail within their paper. They report on the time for the kids to fall asleep. They report on the rest that kids get during sleep, how often they wake up within an hour time interval during sleep, etc., etc. And we know that also from some of the mouse models of MAGEL2 deficiency, that when you take out the gene of the organism, it causes alterations in circadian rhythm and it causes alterations in sleep. But on top of that, there's sleep apnea, so breath holding during sleep. And in the majority of cases, that is an obstructive sleep apnea. Now, typically obstructive sleep apnea is, well known in the medical community, and there's a strong relationship between morbid obesity and obstructive sleep apnea. So obstructive sleep apnea is also commonly seen in elderly people, especially people who are overweight. But what Weston and Joanna found in their study, that obesity alone does not explain the high prevalence of obstructive sleep apnea in Schaaf-Yang syndrome. There's got to be something on top of that. And we believe that on top of that, there is certainly the low muscle tone, which also affects the musculature of the throat and the whole respiratory tract, which causes collapse of the airway, and with that obstruction and obstructive sleep apnea. But there may be more intrinsic mechanisms leading to obstructive sleep apnea in Schaaf-Yang syndrome. Weston and Joanna also make a point in their discussions and in their conclusions that a sleep study is necessary prior to the initiation of growth hormone treatment. That relates to Prader-Willi syndrome, where growth hormone is an established therapy. But in some kids who had severe sleep apnea prior to the initiation of therapy with growth hormone, had severe complications, in a few cases fatal complications, with sudden death caused in relationship to the growth hormone treatment. So we would consider severe sleep apnea a risk factor, and we would be hesitant to initiate growth hormone treatment in those children. And then also the sleep apnea may need to be monitored when kids are put on growth hormone treatment. They also make a point that any child with Schaaf-Yang syndrome should get a sleep study at the time they diagnosed, and that they should be under the care of sleep specialists at a children's hospital. In addition, they found that periodic limb movement, so abnormal movement of the extremities, is present in about 26% of the cohort, and that in addition to the sleep apnea and everything else, can lead to quite an unrestful sleep pattern in the affected individuals. Okay, I have one last polling question for you, Susan, if you could pull that up for me, please. Okay, now we want to talk about adults with Schaaf-Yang syndrome. What are your main concerns when you think about your child becoming an adult with Schaaf-Yang syndrome? Are you mostly concerned about intellectual disability, not being able to take care of himself or herself? Are you mostly concerned about psychiatric disease, about eating behavior and being overweight? Oh, and then Susan put something that I wrote to have the question asked in a way so that, so the fourth point is, are you mostly concerned about questions of being able to have children and the risk of transmission? So your child with Schaaf-Yang syndrome having children, him or herself, and then transmitting the disease to your grandchildren. And then I think the question was also made in a way that you can put multiples of those. You can not only answer one of those, but you can hit multiple of those points. So if there are multiple areas where you have strong concerns, you may want to choose all of them. Okay. Okay, so we do see that some of you chose multiple areas. But the main concern that you have, and I think that is also what I see in clinical practice, you are mostly concerned about the cognitive impairment. And you wonder, will my child ever get to the point so that he or she can take care of himself or herself? And that goes along with the question of, what happens when I and my spouse pass away and we are not able to take care of our child anymore? Who will take care of him or her? And how will that look like? But about a third of you or a quarter of you are also concerned about psychiatric disease and eating behavior. And only a small minority is concerned about passing this on. And that may relate to the fact that some of you at least feel that it's fairly unlikely that your child will pass it on to his children, to her children. Some of that goes along with the hypogonadism. Some of that goes along with the intellectual disability. And some of that goes along with you taking care of your children and taking precautions when they go through puberty, when they become adults, that you have taken measures or will take measures of contraception for your child. Okay, so we can close that. And I will move on to some information about the adult phenotype of Schaaf-Yang syndrome. This is really new information, and as I mentioned, the paper was only published, was only accepted for publication, I think it was last week, and hasn't really come out yet. So you can't find it anywhere yet because the journal at this point is editing the paper and putting it all into a nice shape, and then we'll publish it at some point. It's a collaboration by many groups because we had to pull information from individuals from multiple countries and multiple groups. There, in this study, actually a lot of German patients in there. And it was led by Alma Küchler, who runs the genetics clinic at the University Hospital of Essen in Germany, in collaboration with Felix Marbach, who is a young physician in my team, whose main research project is now Schaaf-Yang syndrome. And also I've been helping as much as I could. It's still a limited number of individuals that we report here. There are certainly more adult patients with Schaaf-Yang syndrome out there, but these are the ones for whom we were able to get consent and get the clinical information. In this study, we report 7 individuals with the typical type of mutation, which is one of those truncating mutations that we mentioned before. And then there's an 8th patient who's kind of always a little on the side because that patient has a somewhat unusual mutation and is not a truncating mutation per se. So we're keeping that person who's a man in his mid-50s a little separate. Now, what you can see here are pictures of 4 individuals showing them when they were children and then showing them again when they are adults. So you can see that some of the features kind of persist, and you certainly recognize the facial features that are somewhat similar between the children and the young men and women when they grew up. There's one feature that you may already realize here, and that is that body weight appears to become somewhat more of an issue when those individuals become older. And we see that pictured on the slide here. Also, we list the BMI of those 8 individuals. And you do see that we have some BMIs in the 30s, 40s, up to the 50s. So some of these individuals really have obesity. They're not just overweight, they're obese. And some of them have morbid obesity. This is somewhat surprising to us because I, for one, proposed for a long time that one of the distinguishing features between Prader-Willi syndrome and Schaaf-Yang syndrome is the low prevalence of obesity within the Schaaf-Yang cohort. Now, this picture and perception may change over time, and this may be one of the first studies suggesting some of that. and that is that maybe the emergence of obesity and excessive food intake may just be shifted somewhat into the older adolescent age and adult age, and the onset of obesity may not be quite as severe as we see it in Prader-Willi syndrome, and it may be later than what we see in Prader-Willi syndrome, but it may still be present and may still be part of the disease. You also get some information about IQ function, and this appears to be somewhat encouraging, because for those individuals for whom we were able to get the IQ scores, you see mild intellectual disability in 3, and you see learning disability, but an IQ that's in the low normal range, actually the borderline intellectual functioning range, in 2 of those individuals. Now, I cannot promise you that that is the natural course of the disease, that IQ function will actually get better in your children over time. It may also be an ascertainment bias of the study, that we were not able to pull the more severely or most severely affected individuals into our study here. Here's some more information about food intake and sleep. So we do see that overeating and food-seeking behavior, some features that are typically reported in Prader-Willi syndrome, are present at least in a subset of those individuals. And in some of those individuals, they are a main feature. In fact, some of those individuals, their caretakers or their parents report to us that this has become one of the major issues in their life, because this is one of the topics where they spend most time discussing and restricting. We do also see sleep apnea still present in many of them. So many of these individuals are on BiPAP machines at night to assist them with their respirations during sleep. And as a consequence of the obesity, the altered circadian rhythm, and the altered sleeping behavior, we do see excessive sleeping and daytime fatigue present in almost all of those adult individuals. Another feature that was reported to us is constipation. Constipation is already an issue in some of your children, but is something that really bothers some of those adult individuals, such that they need treatment for that. Some of them need enemas or other measures in order to keep them going to the bathroom. We also queried information about behavior and psyche, and we do see that unusual or altered behaviors are an issue, not only in childhood and adolescence, but also, and maybe even more pronounced, in the adult age. So we see a lot of individuals for whom stubbornness and unusual behaviors are reported. Those are more of an issue to their surroundings. They don't really bother them themselves. What bothers the individuals themselves are anxiety. So we do see a high level of anxiety and high prevalence of anxiety. We do see some depressive mood. Some of them have had suicidal ideations. And we do see social withdrawal and restricted interests, which really makes it challenging for them to interact with their surroundings, and can also be kind of a vicious cycle when they withdraw and they have depression, and it may just really make them blue and feeling down. Autonomy and activity, so that really relates to what you are concerned with. Will my child be able to live independently? We can see that here, so and you will see it in the publication as well. Can take care of basic needs. Many of them can take care of like dressing and like regular body care and things like that. Some of them, about half of them, engages in work, typically in a sheltered workshop, like a special environment where they can do fairly simple tasks, but they may earn some of their own money and they have some budget. And some of them, live dependently in a completely supervised situation. Others live semi-independently, where they live in a group home or in a certain setting where they live with flatmates without 24/7 supervision, and they just have individuals come in and help them with certain things at certain times. So that being said, you realize it is a long journey, and you may feel somewhat overwhelmed with some of the information that I presented to you today. But I want to assure you that we're all in this together. And it gets back to Hannah Hanners, who said, you know, I finally feel that I'm no longer alone because I have this tribe now. I have this group of people I can rely on. And that's all of you amongst one another. And you are an incredibly strong group of people. And you have been incredibly important to one another. And I think there's a lot of wonderful dynamic going on. But also I want to assure you that we as physicians and researchers are in this with you all. And we are not giving up on you. And we keep working with you and for you to better understand the disease and to find treatment options for individuals with Schaaf-Yang syndrome. And with that, I have my last 2 or 3 slides, and I just want to briefly highlight some of the work that we are doing. Some of you have been so generous to allow us to do skin biopsies on your children, and we have established fibroblast cell lines in the laboratory. With the technology that we have available, we were able to reprogram those skin cells into stem cells, and then we are able to differentiate the stem cells into neurons, meaning brain cells. So without doing very invasive procedures, we can actually generate neurons from your children that give us information about the various pathways and functions that are altered as a result of Schaaf-Yang syndrome. And one of the things that we found, Emmeline Crutcher, who was a very talented PhD student in my lab, she found that in Schaaf-Yang syndrome neurons, there's a certain pathway that is upregulated, and that is the mTOR pathway. And the mTOR pathway is a very well-known, very extensively studied pathway that plays a role in many different functions of the cell, including the synthesis of lipids, but also the synthesis of proteins, growth and proliferation, but also autophagy and the self-control of the cell and kind of the cell limiting its own lifespan. What's very important and exciting to us and you is that the mTOR pathway can be targeted with a drug that is called rapamycin, and rapamycin is an inhibitor of mTOR. So this gives us some therapeutic potential, because if mTOR is high, like we find in Schaaf-Yang syndrome, we can potentially suppress that upregulation by giving rapamycin. And rapamycin is a drug that's known, for which we have a safety profile that's already used for other indications and other disorders. So in the neurons generated from some of your children, we found that there are structural and functional alterations. In part, we find that there's abnormal branching of the neurons. And I won't go into much detail, but you can see that on the graph here on the left. We see the control neurons in green. We see the Schaaf-Yang neurons in red. You see that the number and the complexity of the branching of the neurons is decreased. And then you can see when we give rapamycin to those neurons here in blue, we can rescue the deficit that we see in Schaaf-Yang syndrome. That is in a dish only, but now we have an in vivo, in-organism study that's currently ongoing. Unfortunately, that study was paused for a few months because of COVID-19, where we had to shut down our research labs and part of the animal facility. But this is an ongoing study, and we will complete that study. It is funded by FPWR. So with that, I want to thank FPWR for the generous support over all the years, and in particular for that study. That study has 2 different arms. in one part of the study, we treat mothers who are pregnant with babies, some of whom have the MAGEL2 mutation, prenatally with rapamycin, and we look at whether the prenatal treatment can rescue the survival of those baby mice with Schaaf-Yang syndrome, because Rachel and others have found in the past that some of those Schaaf-Yang mice die before birth or shortly after birth. And then in the second arm of the study, we just, don't mess with the pregnancy. The babies are born. We actually give them a few weeks without treatment, kind of mimicking the clinical situation where Schaaf-Yang syndrome is only diagnosed at some point postnatally during childhood. And then we start the postnatal treatment with rapamycin, and we want to find out if we can rescue some of the deficits that we see in those mice. And we look in particular on muscle strength and endurance, because those are easily quantifiable outcome measures. So those are ongoing, and we greatly look forward to the results of those studies. And once that all has been analyzed and validated and peer-reviewed, I will be happy to share with you all. So with that, I'm at the end of my presentation. I promised you to give you my email address. I still have my American email address, which is very convenient because it's so short. Then I also have the German email address on the bottom. And I wanted to share with you some exciting news. I have had a gap and some challenges with my research coordinator in Houston after I had moved to Germany. But we have a new research coordinator who's coming to join our team, and she's starting on October 10th. Her name is Pilar Caro, or full name Maria Pilar Caro Martin, and she is Spanish speaking, which is also a great asset because my Spanish is really poor, and so she can help better communicate with our Spanish speaking families. So with that, I want to thank you for listening. I know I talked a lot, and I look forward to your questions.
Dr. Schaaf, thank you so much. That was an incredible presentation, and I loved the visual of the genetics, the chromosomes, that really explained the genetics behind Schaaf-Yang. So thank you for spelling that out for everybody. We have a number of questions that have both been submitted on today's webinar as well as pre-submitted. Just want to remind everyone, we have 66 attendees on today's call. If
Awesome.
you have questions, please feel free to enter them into the Q&A. And Dr. Schaaf has also given you his email address. So if we can't answer a question today, you are welcome to reach out to him later on. Let's see. So it's about 1:30. We were going to go to break around this time, but I promised everyone that we would answer as many questions as we can. So if Dr. Schaaf, if you're okay going through the break for a bit, we'll go ahead and go into some questions.
I'm good, and I'm sorry I talked too long.
Please don't apologize. We purposely did this because you have a lot of information to share, and our parents really wanted to hear from you. So here we go. Let's go ahead and start. You mentioned a database and that you wanted to have parents submit the genetic tests to be included in there. How can parents verify that they're in that database?
So basically, at this point, you could just send me an email and ask if we have your information in our database. There are, and I realize this is, not ideal, but it kind of has historic reasons, because when I started learning about MAGEL2, nobody else was interested in it. So we just started our own Excel spreadsheet and put, information for all the individuals who we consented. And so we're keeping that database here, and that's typically run by my research coordinator. Now, more recently, we've also been in discussion with FPWR about having really a database where we also keep longitudinal information and much more extensive clinical information. And in discussion with some of you who are on the Family Advisory Board of FPWR, in particular Kim Nelson and others, we have kind of talked through and thought about whether we should be submitting to the Prader-Willi syndrome database that's run by FPWR, or whether we should be submitting to the Simons Foundation, the Safari Gene database. and some of that is still ongoing. But at this point, I think the most comprehensive database in regards of number of individuals is the one that we have. And if you want to find out if we have your information here, just send me an email and I will have that checked.
Fantastic. Lots of questions here. You talked about the genetics of MAGEL2 and how certain mutations were perhaps less symptomatic than others. Is deletion of the entire MAGEL2 gene, so you have a mutation, if we remove the gene altogether, does that improve our outcomes, and is that a potential treatment?
Okay, so that's an interesting question. You know, we know of a few, it's a very small number of individuals, but there are a few individuals who have been reported in the literature. I'm aware of 2 individuals with whole gene deletions that are in the literature. And those 2 individuals have very, very mild features, which is really surprising because like you would think that if the whole thing is missing, it's actually more severe than just a letter being changed. And we still have to find out why that is. Now, there have been at least 2 more individuals who have been reported to me personally, but they have not been published in the literature, who have whole gene deletions and they have pretty typical features of Schaaf-Yang syndrome. So I'm not entirely sure and entirely confident that missing the whole gene will improve the situation. It's an interesting therapeutic thought, whether one could just delete the whole thing, but I'm not sure it's something that is within reach, because you would have to delete it or block it, you know, in the entire body, in particular in the brain, so that medication that would either block the abnormal MAGEL2 protein would need to cross the blood-brain barrier or be injected into the central nervous system, or you would have to find a way to genetically manipulate through various technologies to cut it out. I think that is a strategy that could be tested in some of the systems that we use. So in fact, I mentioned our studies on iPSCs and neurons of Schaaf-Yang syndrome individuals. We just got iPSCs shipped from the United States that have alterations that are more similar to Prader-Willi syndrome, where we will look at whether those have the same alterations in the mTOR pathway, if those can be treated with rapamycin. And in those, we can also look at some of those things that relate to blocking MAGEL2, deleting MAGEL2, what are the consequences of each, what happens when you delete MAGEL2 from the paternal copy, what is the effect on the maternal copy. There's some evidence from Françoise Muscatelli in France from mice that when you delete the whole thing on the paternal copy, that it kind of slightly increases the expression or releases the expression from the maternal copy. Those are some of the research avenues that will be very exciting over the next few years.
Great. Let's talk about scoliosis for a moment. How prevalent is scoliosis? At what age does it typically appear? And would the treatment protocol be similar to that as Prader-Willi syndrome?
Good question. I don't think I'm the best person to answer that because obviously I'm not an orthopedic surgeon. What I do know is that based on the data that we have assembled, it appears that maybe 40 to 50% of all children with Schaaf-Yang syndrome have scoliosis. The severity varies. Oftentimes, scoliosis is present within, let's say, the first 5-6 years of life. But in many cases, when it's present, it does get worse over time, especially when they get a growth spurt during teenage years. There have also been concerns that scoliosis may worsen under growth hormone treatment. So that's something to consider. And I know there have been discussions in the Facebook group about the best way to approach scoliosis, because I realize some of your children have scoliosis of 50, 60, 70, 90 degrees, and they require scoliosis surgery and rod implantations, et cetera, et cetera.
Great. We are having an orthopedic session during the PWS Family Conference with Dr. Van Bossi. So if anyone is concerned about scoliosis, I would recommend attending that session. He will be speaking specifically to PWS, but given the prevalence of the Schaaf-Yang community, he may be a wonderful resource for you.
And he is outstanding. He is certainly, at least to my knowledge, the orthopedic surgeon with the most advanced knowledge about PWS. And I have referred some of you to him and his email address, and so that he can kind of share information with you all.
Thank you. How about autism? We're getting a lot of questions regarding the prevalence of autism.
So you know that Donnie had autism, and that's the reason why he came to clinic. And in our initial publication, we said, you know, mutations in MAGEL2 cause an autism spectrum disorder. That is still true. It appears that up to 80% of your children have a diagnosis of autism spectrum disorder. There's a study, like an in-depth evaluation of a limited number of individuals who we asked to come to Texas Children's Hospital and were evaluated at the Texas Children's Hospital Autism Center by Dr. Berry and Dr. Kotschel and their team. And there's a publication of that study available, which also in the past I shared in the Facebook group. Where we found that also when we apply the most stringent measures of autism diagnosis, the gold standards, many, if not most of all of your children do meet the criteria for autism spectrum disorder. So it's highly prevalent. In some, they may not meet the points to get the formal diagnosis, but they still have autistic features. And I know that some of you have then actually tried to still get the diagnosis of suspected autism spectrum disorder in writing because it allowed you to get access to additional resources within the healthcare system. So that I cannot really comment on, but I realize that having the diagnosis of autism spectrum disorder sometimes opens doors to additional therapies, including, and that may be particularly important to some of the high functioning or higher functioning kids with Schaaf-Yang syndrome, to ABA therapy, adaptive behavior analysis, which may improve the social outcomes of your children.
Absolutely. How about pain tolerance? Have you found that individuals with Schaaf-Yang syndrome have a higher tolerance for pain?
So we have heard about that, and I think at some point we included that information in a questionnaire. So a good number of your children appear to have a higher pain tolerance, such that they tolerate pain and they hurt themselves without crying or complaining about it. And later you realize that they have injured themselves. This could be particularly troublesome when they get older and in conjunction with the abnormal bone metabolism. So in one of our studies, we also showed that the bone mineral density is decreased in many of your children, in some of them causing, you know, real and profound osteoporosis. So they at risk of breaking bones when they fall, and if they don't have the pain perception, they may even break a bone and not complain about it, which then could cause more challenges. So that's certainly something to keep an eye on. And I do recommend for all children when they're 5 years or older to have their bone mineral density looked at. And if it's decreased, at least to consider optimizing with vitamin D and calcium supplementation.
Great advice. Are you aware of symptoms like cyclic vomiting syndrome? We have a parent whose daughter is struggling with this. Are there other individuals that you know of that might have the same challenge?
So a lot of kids with Schaaf-Yang have GERD, gastroesophageal reflux disease. And with that, they may vomit. But cyclic vomiting syndrome is typically something that comes from the brain. And I have heard that diagnosis in maybe 3 or 4 of the families that we've been in touch with. So it could be that this is something that's overrepresented in Schaaf-Yang syndrome compared to the general population, but it's certainly something that we haven't looked at very deeply, and also something for which I do not have a very good explanation.
Great. So perhaps this parent, if she has more questions, should email you offline and you guys could talk about it a little bit further.
Absolutely.
Fantastic. So sleep is a huge issue with people with Schaaf-Yang syndrome. We hear stories of kiddos who have very abnormal nighttime sleep patterns. It could be a real challenge for the families. Are there any sleep remedies that you found that work? Are there new drugs that are perhaps being looked at for Prader-Willi syndrome or other narcolepsy groups that might be relevant to Schaaf-Yang? What do you think there?
Yeah, so again, I have to kind of show my ignorance and kind of limitations, because, as I learn more about Schaaf-Yang syndrome, I also kind of try to learn more about other subspecialties of medicine. So there's a lot that I do not know about how to treat narcolepsy and things, but I do know for sure that given the alterations in circadian rhythm, many of your children have difficulties falling asleep. And I do know that many of your children are taking melatonin. And I strongly believe that is something to be considered, because at least it will help them fall asleep. It should not interfere with their sleep apnea. It will not help them sleep through the entire night, because they may still be restless and wake up in the middle of the night, but at least it helps them fall asleep at an appropriate time.
Fantastic. And let's talk about growth hormone for a little bit. My understanding is that there is not an indication for growth hormone specifically for Schaaf-Yang, so it can be tricky to get it covered by insurance. Is there any tips or tricks for getting this covered for our Schaaf-Yang families?
So I think, first of all, you need to find a pediatric endocrinologist at a tertiary medical center. I believe when they, in an academic environment, they more open to looking at the literature and kind of, more willing to recognize that this is a very rare indication, and that they may just go with an off-label prescription, even though it's not FDA approved for this particular indication at that given time. I know that a few families have also switched pediatric endocrinologists if one wasn't willing to give it, and then the second, they found someone who was willing to give it. For a fairly large number of families, I was asked to provide a letter explaining the relationship and also explaining our somewhat limited but still existing experience with growth hormone in the patient cohort, and many families were then able to get the prescription kind of following that letter. So I'm happy to help with that. I still believe that we need to investigate that further and also kind of show what we know in the medical literature. So I think the questionnaire that we will be sending out to you all soon will be a first step in gathering information. At some point, that's really still kind of a big question. Do we need to do a clinical trial with growth hormone in Schaaf-Yang syndrome? On one hand, it would be ideal to have that to really document the advantages of growth hormone. On the other hand, at this point, it almost seems like we wouldn't be able to do a blinded study because we cannot ethnically explain and justify to you all that we would be putting some of your kids on a placebo. because many of you wouldn't agree to having your child on a placebo if you can get growth hormone anyways through an endocrinologist. And then many kids who have been on growth hormone already wouldn't be eligible for the study maybe.
Do you personally recommend that all patients with Schaaf-Yang are on growth hormone if possible?
So I certainly do recommend to consider. I do recommend the evaluation in pediatric endocrinology looking at growth hormone. So there are easy blood tests that you can do looking at IGF-1 and IGF-BP3. There are more involved tests with a stimulation test. But even if you do not have a measurable growth hormone deficiency, I do encourage to consider growth hormone treatment because you may still see beneficial effects. However, I strongly encourage everybody to get a sleep study first and discuss with the pediatric endocrinologists the risks that come with growth hormone. I mean, it's not an easy treatment because it's not just a pill that you take, it's a daily injection that you have to get used to. And there are some risks that come along with the treatment that should be explained to you.
Right. We have a lot of questions around some of the behavioral challenges that can come with this syndrome, including anxiety, OCD, perseveration, and distractibility. These are all behavioral issues. Are there remedies or treatments that parents can consider to help with some of these challenges?
So again, that's like one of my weaknesses as a geneticist. I don't really prescribe medications to my patients, but I would refer them to my colleagues in child psychiatry or adult psychiatry. There's not a single medication that would help all. And at this point, treatments on the psych side of life are all symptomatic. So what the psychiatrist will do, he or she will look very carefully at the symptoms that your child shows. And depending on what's most prevalent, they would then give a medication that would help in particular with the anxiety or the depression, the ADHD, or the psychosis. So the medications prescribed would be similar to those prescribed to other children that have a diagnosis of either ADHD or schizophrenia or depression or anxiety. I've seen some kids even on 2 or 3 drugs that interfere with the psyche. Some show reasonable improvement. In some, the side effects of those drugs are stronger than the benefit that you see. There's certainly not a single medication at this point that would help all.
And that's true for the Prader-Willi syndrome group as well. We have the same symptoms, and what we found is you have to try different medications. Some of them work, some of them don't. That's no different than the typical population. Is there an expert that you're aware of that our Schaaf-Yang families could use as a resource as they're going through this journey, looking for psychiatric help? Is there anyone who's identified themselves as working with a lot of Schaaf-Yang families?
So really, there's not a person who has taking care of many individuals with Schaaf-Yang syndrome on the psych side. We do have Leandra Berry, who's a clinical psychologist at Texas Children's Hospital, who was engaged with our autism study. So things that relate to autism, she would be a good person to talk to. Because she's very experienced with autism, but also she has seen at least 10 or 15 individuals with Schaaf-Yang syndrome herself. I do have a child psychiatrist at Texas Children's Hospital who came from Iowa a few years ago. His name is Chadi Kalarji. And I have referred 2 or 3 patients to him, and I've sent him emails of a handful of families also over the years. But I would not say that at this point, he is an expert yet. And he hasn't really been engaged in any of the research studies that delve deeper into Schaaf-Yang. So in fact, it would be good to find a person who's really engaged and interested on that side.
Mm-hmm. Absolutely. And just as an advice as from a parent to a parent, engaging with a professional who can join your team early on is important. You want to have this person on your team before you need this person, because when anxiety gets bad or OCD gets bad, it could really impact the family dynamics. And it's nice to have that person who you have a relationship with, so that you're not on an extensive waiting list to be seen. So we have a question about CBC.
I will make one more comment, please, Susan. Also, I would like to encourage you, if you find an awesome psychiatrist in an academic setting who really shows interest in your child, maybe you can engage him or her and get him or her interested in Schaaf-Yang syndrome. I mean, somewhat similar situation with Joanna Reed, who's a sleep specialist who published, that paper that I mentioned, who saw, her first child with Schaaf-Yang syndrome and got really interested in that particular case. And the family encouraged her to look deeper. And then she saw another family at the same hospital. But, to engage these young professionals, highly motivated professionals, who maybe, some people in academia, especially in the clinical disciplines, are actually looking for research projects because they need to show academic productivity. So if you find someone who you feel like is really willing to put all his effort into this, refer them to me, and I'm happy to help them kind of get that research project off the ground.
What a great suggestion. A lot of work that has been done in research has really been stemmed from parents bringing people together. So, as parents in this community, we really value your efforts to continue to build this program up. What about CBD? Is there any research that's taken place regarding CBD helping individuals with Schaaf-Yang?
So that's cannabis, or?
Correct. CBD oil, I assume.
Yeah. I don't know. I'm not aware of any research. And I've been asked that question 1 or 2 times before, and I simply don't know.
And I think that's true for a lot of syndromes as well. The jury is out on that. Okay, let's go back to some of the genetics and family planning, because that is of concern to a number of people. If you have one child with Schaaf-Yang and you want to have more children, and your child has Schaaf-Yang as a inherited gene mutation, are there any specifics that need to be considered for IVF? Should we be requesting certain testing or anything of that sort?
Yes. So if the dad carries the MAGEL2 mutation, and you have a child with Schaaf-Yang syndrome, either yourself or in the family, you should or could consider pre-implantation genetic testing. And I know that some families have gone that way. So that would mean that you would have the conception in vitro, an IVF baby, and then in an ideal situation, multiple embryos would develop, and then they will be allowed to grow and divide for a few days. And then either one cell or like a small number of cells will be taken away from each embryo. And then the embryos will be tested for whether they carry the mutation or they don't. And then only an embryo or embryos that do not carry the mutation will be implanted. So that is an option in the United States, in Germany, in many of the European countries. If dad is not a carrier, I mentioned the small chance of a germ cell mosaicism. in most countries and situations that would not make you qualify for pre-implantation genetic testing, because the ethics committee would argue, and I think for good reason, that your chances of having another child with Schaaf-Yang syndrome are not substantially enough increased to allow for pre-implantation genetic testing. Because the ethical downside of that technology obviously is that we may generate multiple embryos that will then not be implanted eventually, and that would then have to be discarded or be donated for research.
We are really coming up on time, so I'm gonna ask one final question. And again, if you guys have more questions after this session, please email Dr. Schaaf. I threw his email into the chat, so it's there for you if you wanted to copy it for later. How about if a person has severe apnea, are they still able to have growth hormone treatment, or does that preclude them?
Yeah, so that's really a decision that needs to be made between the sleep specialist and the pediatric endocrinologist. And maybe, Susan, you know from the Prader-Willi community how that's being handled. Typically, I believe that severe sleep apnea would prohibit growth hormone treatment. But there could be measures taken that could alleviate the situation. So in some cases, tonsillectomy and adenoidectomy will actually improve the obstructive sleep apnea and may shift severe obstructive sleep apnea to a mild or moderate degree sleep apnea, and then your child may be eligible. But that's something that really needs to be considered as a team approach.
Wonderful. Okay, so we are going to take a very quick break, 5 minutes. But before we go, I just wanted to say that a lot of, all of the Schaaf-Yang research that is taking place right now, a lot of that is being funded because of you, because of the fundraising and donations that have been made to FPWR. So if you're so inclined to ensure that research continues for Schaaf-Yang research, please consider fundraising or donating so that we can continue to support these amazing researchers that you're hearing today.